عاصم and الشريف. Today our topic is going to be on IPS treatment update. IPS remains one of the most common GIT disorders seen by clinicians that greatly reduce patients' quality of life and hugely affect the economy. And according to Rule 4 criteria, IPS is defined as recurrent abdominal pain on an average once per week in the last 3 months, associated with 2 or more of the following criteria. One is related to irritation or associated with a change in the frequency or in the form of the stool. Another definition we got by the British Society of Gastroenterology this year that IPS can be defined as abdominal pain or discomfort in association with altered bowel habit for at least 6 months in the absence of any alarm signs or symptoms. And in a study published in the Nature last year, it stated that the global prevalence of IPS is approximately 11%. And another study published in Saudi Arabia and stated that the prevalence is approximately close, which is estimated to be 8.8%. IPS is categorized based on the Bristol stool scale into IPS predominant constipation, IPS predominant diarrhea, mixed type, undetermined type. And the prevalence of IPS predominant diarrhea is usually equal in both male and females, but it is more common in females in patients with IPS predominant constipation. And almost about 30% of the patients seeks medical help, and it is usually common between the 4th and the 6th decades of life. IPS treatment market size have been increasing in the last decades and is expected to be increased in the coming 10 years. And the economic burden is divided into indirect costs, which is estimated to be 20 billion, including absenteeism, decreased productivity at work, and direct costs, which is estimated to be 10 billion, including prescriptions, investigation, and medical visits. There are many proposed causes and triggering factors for IPS, including stress, abnormal transit and motility, genetics, dysbiosis, infection, abnormal immune regulation, food intolerance, altered visceral perception. And perhaps the most accepted theory is the stress, either psychological stress or physical stress, which leads to release of the corticotropin releasing hormone from the hypothalamus. This is what leads to cortisol secretion from the adrenal gland, changing in the microbiota profile, end up into alteration in the permeability of the intestine, and finally dysbiosis. And when dysbiosis happens, this leads to increase the pro-inflammatory cytokine release, including the interleukin-1b, tumor necrosis factor. And when we got these 3 factors, disturbed microbiota, immune activation, and barrier dysfunction, this will end up into altered cognition, behavior, emotion, and nociception. And this will end up in distress and again start the circle. And this is what we call the gut-brain axis, which both affect each other. So the question is how to manage. Starting with the diagnosis, according to the American College of Gastroenterology this year, it stated that we recommend delaying diagnostic workup when possible and treating patient empirically, depending only on the symptoms of the Room 4 criteria. So this is what we call the positive diagnostic strategy. So we don't depend on investigation, we just depend on the symptoms of the patient mentioned in the Room 4 criteria. Also, the Japanese guideline support this idea, and they stated that Room 4 criteria are useful for the diagnosis of IPS. But the question is that enough? We depend only on the symptoms, like patient coming to me with abdominal pain, with change in the form or the frequency of the stool, and this is happening too much in our clinic, so maybe related to many other diseases. Until we got the British guideline this year, which stated that to make a positive diagnosis of IPS, we need 3 factors. We need symptoms, we need very good history, including medication, comorbidities, other functional non-GIT disorders, and also depend on baseline investigation, including CPC, CRP, ESR, celiac studies, fecal calprotectin, other investigations to exclude colorectal cancer or ovarian cancer. So by this 3 factors, we can make a good positive diagnosis of IPS, which I believe is more accurate. Treatment usually include lifestyle changes, pharmacological treatment, psychotherapy, and other treatment options. And starting with the exercise, we found that exercise can accelerate the GIT tract and improve the intestinal gas clearance, increase gut microbial diversity. And we got agreement between the British and Japanese guidelines regarding exercise, but we don't have no data regarding the American guidelines. And a systemic review of 14 randomized studies reported that 1 hour of yoga per day, or half an hour of walking, or half an hour of aerobic exercise can definitely and significantly improve the IPS symptoms. And this is what we call the IPS food pyramid, and starting usually with the healthy eating habits, increasing any kind of vegetable, the fruit, avoid the spicy food, the fatty meals, and stuff like that. And many randomized controlled studies found that food elimination based on IgG antibodies, which is usually commonly used nowadays, may be effective in reducing IPS, but still all the guidelines have no recommendation regarding the food elimination based on IgG antibodies. Soluble fibers could be also a good option in patients with IPS, as it exerts laxative effect and tends to increase stool water content, as oats, beans, strawberries, apples, nuts, seeds. While insoluble fibers, usually we don't recommend it as it aggravates the gas and bloating symptoms. We also have agreement between all guidelines to use the soluble fiber in patients with IPS. In a randomized controlled study, comparing the efficacy of soluble fibers and comparing to a placebo and insoluble fiber, and they found a significant improvement in abdominal pain, even frequency or the intensity in patients using soluble fibers. Then what we got recently, what we call the low food map diet, fermentile oligosaccharide, disaccharides, monosaccharides, and polyols, which usually gained popularity in the last 5 years. As you all know, the food map diet increase the fermentation in the colon, so increase the shorter chain fatty acids, and this is lead to luminal distension and symptoms worsening. This is the symptom. This is the kind of food that we have to avoid, and the other side, the kind of food that we have to use. We also got agreement between the British and the American guidelines regarding the low food map diet, but we don't have the data regarding the Japanese guidelines. What about the probiotics? Probiotics, as you all know, it improves the dysbiosis, so this is interfered with dysbiogenesis. And for the first time this year, according to the British Society of Gastroenterology, stated that probiotics can be treated at a first line in patients with IPS for a period up to 12 weeks. Also, the Japanese guidelines supported this treatment, but the American guideline suggests against the probiotic, and they stated that more rigorous standards need to be set by the US FDA. Antispasmodic, one of the treatment of IPS, remains one of the most frequently used, and we got many different kinds of antispasmodic with different mechanism of action. And also we got agreement between the British and Japanese guidelines regarding using of antispasmodic, but the American guidelines in 2018 support the antispasmodic. Then again, 3 years later, they recommend against the use of antispasmodic, and they stated that needs further evaluation. Laxative also can be used, and the British and the American guideline support the polyethylene glycol, one of the osmotic laxatives, and the Japanese guideline support post-osmotic and stimulant laxatives. Then we got a set of rules for drugs for patients with IPS, predominant constipation, what we call the tigacerode and prucalopride. Tigacerode is a serotonin receptor agonist and FDA approved. Prucalopride approved only by the European guidelines in chronic constipation, and both have a prokinetic effect, and they, as you see here, they can enhance the antral motility, they can enhance the gastric emptying, increase the lower esophageal sphincter tone, esophageal peristalsis. But this drug was withdrawn from the market in 2007 due to causing cardiac ischemia, and then reintroduced again in 2018 in only female patients under the age of 65 with no pre-existing cardiovascular disease. And also we got agreement between the old guidelines using the tigacerode in patients with IPS. We have also a new set of drugs, what we call the intestinal secretagogues, which is available now in Egypt in IPS predominant constipation patient. We got ropepristone and linaclotide. Lupipriston, as you know, is a chloride channel activator. It stimulates the chloride channel, releasing the chloride ion into the intestinal lumen. And this is followed by sodium and water, which increase the water secretion and increase the intestinal motility and stool passage. Linaclotide acts by stimulating the guanylate cyclase receptor, which leads to increase the cycle of GNP, stimulating the protein kinase 2, and this is again leads to chloride channel activation and followed by sodium and water. It also has another action that increases the visceral hypersensitivity by decreasing the afferent pain fibers, inhibition of the afferent pain fibers. We got also agreement between the all guidelines regarding using the intestinal secretagogues in patients with IPS with constipation as a second-line drug therapy. Loperamide is also one of the drugs used in IPS predominant diarrhea. It, as you know, it's a weight receptor agonist which leads to inhibition of myotonic plexus activity. And this has increased the intestinal transit time and water reabsorption. And also we got agreement between the British and Japanese guidelines, but we have no data regarding the American guidelines. Rifaximin is also a drug that can be used effectively in patients with IPS predominant diarrhea as it prevents dysbiosis. It is, as you know, bactericidal antibiotic which inhibits bacterial protein synthesis. And also we got again agreement between the all guidelines in patients with IPS as a second-line drug therapy for patients with IPS predominant diarrhea. Tricyclic antidepressant and SSRIs can be used also. As you know, it blocks the stress, so it again interferes with this pathogenesis. So it improves the visceral pain, got an anticholinergic effect, and slows the GIT transit. We also got agreement between the all guidelines regarding the usage of the tricyclic antidepressant, but we don't have agreement still now with the SSRIs in American guidelines. Also we have a new drug, actually it is not new, it is allocetrone, which is a 5-hydroxytryptamine 3 receptor agonist, serotonin receptor antagonist. Its primary mechanism of action is slowing the intestinal transit. It also withdrawn from the market in 2001 and reintroduced again with a lower dose, and it is very effective and also available in Egypt now. We also agreement between the all guidelines regarding using the allocetrone as a second-line therapy for patients with IPS with predominant diarrhea. And lastly, we got the enoxazoline, what we call the mixed opioid receptor. It usually stimulates different kinds of receptors. We got the mu opioid receptor, and we got the delta opioid receptor. Stimulate the mu opioid receptor, this is what leads to slowing of the gut motility and reduction in the visceral pain. While we stimulate the delta opioid receptor, this is will attenuate the effect of the mu opioid stimulation and thus decreasing the side effect of constipation that may happen using this drug. And also we got agreement between the British and the American guidelines regarding using the enoxazoline as a second-line therapy for patients with IPS with predominant diarrhea, but we don't have data regarding the Japanese guidelines. Other treatment options could be psychological therapies, alternative medicine like propionate oil, narcotics, anti-allergic drugs, bile acid sequestrants, fecal microfluidic transplantation. So in conclusion, life is so short. Enjoy your life with delicious meal and forget about IPS. Thank you. So, any question?
It's very important to me to know some details one of the leading causes during the pediatric age group. When they grow up, they will develop inflammatory bowel disease or some sort of psychological problem involving the GID. One of the lines of treatments for the abdominal pain, what's called biofeedback for the control of abdominal pain in children. أنا بصراحة أنا ما فهمتش يعني إيه البايوفيدباك and the use of antidepressants في this age.
هو يعني recently في أمريكا والدول المتقدمة اللي بياكلوا مع الكلاب طحين بيعملوا البايوفيدباك ثيرابي ده يعني some kind of exercise that improve the pelvic muscles. For example, مثلا constipation or patient with IBS with predominant constipation.
Okay.
Certain kinds of exercise, this is what we call the biofeedback therapy. Then when we perform this kind of exercise, this is to improve the flora or the pelvic floor muscles. So improve sometimes the constipation.
بس هي المشكلة مش constipation. العيال زي دول بيبقى completely normal. All the problem is just recurrent abdominal pain, very umbilical, وليها كرايتيريا معينة. والمشكلة فيها إن الثريشولد بتاعهم بإحساسهم بالألم واطي شوية. فعشان كده هو أول ما حد يضايقهم عليهم امتحان بكرة ما أعرفش إيه يجيلهم very umbilical pain. فبيقولوا إن البايو فيدباك بيفيدهم وما عندهمش لا constipation ولا diarrhea. فبيفيدهم في أنا والجزء ده حاولت أقراه بصراحة ربنا.
هو depend mainly على some sort of exercise. هو ده البايوفيدباك. اتفضل.
هو البايوفيدباك في الاكسرسايز اللي هو اصلا بيقول للبيشنت يوميا هي تخش الحمام الصبح قبل ما ينام باي وقت يخش يقعد على الحمام يعمل without straining just some contraction to relax plus in the examination room in the hospital في nerve stimulation حط على الجهاز nerve بيحسن الاكسرسايز بتاع البلفيك ماسلز اللي هو الليفيتر والمايا عشان يقدر ان هو اي حاجه ما تفضلش موجوده هو مش عنده احساس الفيلينج اوف ذا ايكويشن.
ده احيانا بيحطوا لهم بالونه
ده تيست ده دكتور ده تيست ده مش بايوفيدباك اسمه قولون اكستراكشن
يعني البكتيريا القطعه الموجوده اصلا مع وجود الدستور اللي احنا قاعدين نخلي ايكويشن بيحصل على طول الانتستين. احنا عايزين نقلل الاول اللي بيحصل البيكنج ده نقلل البيكنج وبعد كده نعمل كيلينج للفلورا اللي موجوده في الانتستين وبعد كده نعمل بالبروبايوتيك نعمل بقى كيلينج للكولون
بالانس اللي هو بيسموها.
فهو عن طريق الميكانيزم الاكسرسايز وعن طريق النيرف ستيميوليشن.
هو هي على فكره ده علم كبير جدا وفعلا في ناس بتتحسن جدا جدا عليه يعني في ناس فعلا سامسونج بيقولوا
بس البرانش ده لسه مش مفتوح
عندكم. لا لسه ما فيش ما عندناش اي سنتر في مصر مش يمكن في جامعه عين شمس يمكن عامله سنتر او حاجه لكن احنا في الازهر عندنا ما فيش.
هو الجهاز اللي موجود في الواحد كله
away from control of pain او عيادات الكنترول اوف pain المنتشره دلوقتي.
بالنسبه للهاي بيس بالنسبه للسوريين بالنسبه اللي هم الناس اللي عندهم سبيسيا نتيجه الناس اللي بيكون اصلا عندهم استرايتس وبياخدوا على نتيجه كتب مين ديزيز وبياخدوا مثلا على طول ادويه بلس ان هو بياخد على طول بروتون بامب فطبعا يقدر هو مضطر انه ياخد بروتون بامب. المشكله اصلا عنده في الديسبسل صابت فبيستفيد من الفيدباك.
بس هو طبعا ده يعني طبعا يسمى الكالتشر بتاع مصر مش هيمشي فيه قوي الكلام ده انا متهيألي اظن كده. الكالتشر بتاع مصر
عشان الهم اللي عندهم اعلى من اي بايوفيدباك.
بالظبط. بصي الكالتشر
بلس
صعب قوي مش في الكلام.
هو